Thank you all for joining us this afternoon and this evening. We have an outstanding lineup of expert panelists and talks highlighting structured decision-making in patients with chronic limb-threatening ischemia or CLTI. Patients with CLTI are, of course, one of the most common challenges we all face as vascular specialists, and our goal collectively is to provide the best and most effective care to prevent amputation and maintain patients' ambulatory function for better and healthier lifelong living. Focus of our session tonight is to discuss how a structured approach to decision-making using this plan scheme as based in the Global Vascular Guidelines can help guide individuals to make better informed decisions with their patients about treatment choices they have in CLTI. We'll talk about the importance of using staging to guide the course of treatment, and potential alterations in the treatment plan will be reviewed. We'll talk about the use of a VQI risk calculator, the WIfI staging system, and the glass anatomy system to facilitate these processes of evidence-based decision-making with CLTI patients and their caregivers. If you've not yet done so, please take a moment to complete the pre-survey questions that are showing up on your screen. Your feedback with these pre- and post-survey questions is important to us in developing and delivering important and timely information and medical education to you from the SVS. Our presenters tonight include several experts in the field of PAD and CLTI, including Drs. Misty Humphreys, who will provide an overview of risk estimation using the VQI CLTI calculator. Dr. Joseph Mills, the current president of the SVS, will discuss limb staging using the SVS WIfI scheme. Drs. David Armstrong and Leanna Banyan, who will share interesting and complex case presentations with the group, and Dr. Chris Abulraj, who will wrap up the presentation with a presentation around changing the plan over time based on how the patients respond to treatment. In addition to moderating tonight, I've also prepared a presentation to start off tonight's session on optimizing patient selection and outcomes, employing the plan approach in everyday practice. In the hopes of keeping everyone on time, each presenter has submitted a pre-recorded talk. Please enter your questions in the Q&A as we go. We will follow at the end of all the talks with a panel discussion where we'll try to get to as many of the high-level questions as possible. So without further ado, let's get started with my pre-recorded talk. Thank you to all of our expert panelists and to all of you joining the webinar today. The focus of our discussion today is how to optimize patient selection and outcomes for patients with CLTI undergoing revascularization using a structured approach using the PLAN acronym in everyday practice. These are some of my disclosures. In 2019, the Global Vascular Guidelines was published, which was the effort of many over numerous countries and several societies to address what we felt to be a growing need to provide a better evidence-based framework and standards of care in the arena of chronic limb-threatening ischemia, reflecting that peripheral artery disease is a growing global epidemic, now estimated to affect more than 200 million people, and that up to 11% of these individuals present at the most advanced stage of the disease with chronic limb-threatening ischemia, at which time they have very high risk for mortality, limb loss, and severe disability. Fragmentation of care in these patients is typical, and lack of standards and outcomes and approaches and evidence are critical issues limiting the overall care and the quality of care that can be provided to these patients. So the Global Guidelines was an effort to begin a new framework around optimizing the care of these patients and employing a more structured approach to decision-making. There are many clinical challenges in the management of CLTI that we as vascular specialists encounter on an everyday basis. When we think about trying to apply a more evidence-based algorithmic approach, we recognize from the beginning that CLTI patients have a very broad spectrum of their clinical presentation It's challenging to accurately estimate their overall risk of surgery and also, in some cases, the achievable goals of limb salvage. We need to be able to rapidly assess and accurately stage the severity of limb threat to decide on the urgency of the approach and also the optimal revascularization strategy. How can we estimate the probability of achieving both technical success and clinical success utilizing the array of revascularization tools in current practice? How can we define for the patient and the family the long-term risks of treatment failure and whether or not we would be able to rescue the patient if the initial treatment fails? Optimizing the patients from a medical perspective, both pre, intra, and post-procedure, is vitally important to optimize their survival as well as their quality of life. How and when we decide to re-intervene on these patients, which is a common scenario, and also just how we standardize and improve all the other adjuvant things that are required to care for their wounds, get them healed, return them to full ambulatory function, and prevent them from experiencing recurrent CLTI. These are everyday challenges we all encounter in the management of these complex patients, to which the Global Guidelines tries to address. So a fundamental concept in the guidelines is to apply a more structured, ordered approach to decision-making in these patients by structuring things around three key axes, as we currently do in everyday practice. The first is estimating the risk of mortality for the patient, both in terms of their procedural risk as well as their long-term survivability. The next is estimating the severity of threat to the limb at the time of presentation. And for that, we use WIfI staging. And the last piece is to have an anatomic complexity scale that reflects how we think about revascularization in the limb at risk. And for that, a new system was developed by the Global Guidelines called the GLASS system. We'll go through these during the entire webinar, but in this introductory talk, I just wanted to outline the rationale for each. Ultimately, the goal is to bring all of these pieces together when we're trying to have informed and shared decision-making with the patient and their caregivers and stakeholders so that they can best understand the decisions that we need to make to move forward around limb salvage, revascularization, and other therapies. So there are many tools that have been reported to estimate survival in patients with advanced PAD and CLTI. All of these share common elements such as advanced age, renal disease, diabetes, coronary disease, tissue loss, and ambulatory status, and all of these have been generated primarily retrospectively. The largest one of these efforts from the VQI was published several years ago by Jess Simons and colleagues, and they developed a model based on more than 38,000 patients who had undergone revascularization in VQI for CLTI. And using baseline demographic and clinical features, they could develop a way of predicting their short and long-term survival, which is shown on this curve, with low-risk patients having an estimated survival probability of about 75% at 5 years. The Global Guideline defines a high-risk patient as someone whose expected perioperative mortality might be greater than 5%, or their expected 2-year survival is less than 50%. And this model, risk model, appears to be good at segregating patients with that in mind. When we think about staging the limb, the WIfI system, which was published now 10 years ago, has proven to be valuable and validated in multiple settings. WIfI is based on examining the limb across the three axes of the wound severity, the deficit in perfusion, and the presence and extent of foot infection. It's meant to really be applied to patients with chronic PAD, not to acute limb ischemia or other presentations. Many of you are familiar with the system in that each of these, like a tumor, a T&M type of system, has a 0 to 3 scale. For wounds, it's based on the location, the depth and severity of the ulcer. For ischemia, it's based on non-invasive pressure measurements. And for foot infection, it's based on an infectious disease of society system. When these are combined for each individual presentation. 4 different levels of severity were defined by an expert panel representing the likelihood of amputation at 1 year if not treated successfully. And you can see as we go across the scale of wound, ischemia, and foot infection, the severity of limb threat goes up. This system has now been validated in terms of the 1-year risk for amputation in a large number of studies, only some of which are represented on this slide. You can see that looking at the 1-year risk of amputation, it's very low or negligible for patients presenting at stage 1, whereas at stage 4, it's in the 20+% range, and this is all in series of patients who were treated with revascularization. Stages 2 and 3 are intermediate in risk, and in the current data look like they often overlap in their amputation rates. At our center recently, we published a more long-term follow-up of patients staged initially by WIfI, and you can see that the staging system continues to look valid, now extending out to 2 years and beyond. And of particular note, patients who present with WIfI stage 4 limbs are at most significantly elevated risk, which begins early and continues over time. And you can see that they segregate extremely well, even out to 2 years. So WIfI is also a predictor of longer-term limb outcomes. Finally, we needed a system to better integrate the anatomic complexity faced by the vascular specialist when trying to revascularize patients with CLTI, recognizing that these patients often present with disease in more than one artery segment, and that success generally requires inline flow from the groin to the ankle and foot. The GLASS system is the only system that currently integrates the disease complexity across the femoropopliteal and infrapopliteal arteries and assigns 3 stages of disease based on a chosen primary target artery path. Stage 1 is low complexity disease, where the outcomes of endovascular is expected to be good with a low technical failure rate and a good 1-year limb-based patency, whereas high complexity disease would have a higher expected rate of early technical failure and a relatively low 1-year patency rate from an endovascular approach. Intermediate complexity is exactly that. The scale is created by first grading the lesions that you see on the angiogram in the femoropopliteal segment on the left, and then on the infrapopliteal segment, focusing on your primary target artery, whether it be anterior tibial, posterior tibial, or peroneal for that case. The grading is based on the length of lesions, the location, and whether or not they're chronic occlusions. And you get a grade for the fempop and then a grade for the infrapop disease, and you combine those on this consensus staging scale to see the overall complexity stage for the leg. And once again, you can see that this increases in proportion from the lower corner to the upper right corner as the grade increases in each segment. The GLASS system has also now had lots of early validation reports, including this recent systematic review and meta-analysis. And I'll just point out on the right-hand side, the bottom line here, which is that for patients with the highest level of complexity or Class 3 disease, you can see that there's a significantly increased rate of immediate technical failure at 28%. This is for endovascular only, and a 1-year limb-based patency rate of 40%, consistent with the predictions of the model. Therefore, patients who present with advanced GLASS stage need to be considered as potentially at high risk for both early and late failure from an endovascular standpoint. Each of these calculators is now readily available on a free downloadable mobile app from the SVS app site. You can find the VQI CLTI mortality model, the WIfI staging system, and GLASS, all easily available and handy to use in real-time fashion in the clinic and in the operating room, as well as the cath lab. And the talks that will follow me will go through each of these different calculators with specific examples in detail. So finally, why is this all important? It's important because the best evidence that we have to date suggests that the treatment of patients with CLTI is not a one-size-fits-all strategy, but should be individualized to their appropriate level of risk, limb severity, and anatomic complexity, such that patients who present with an average risk for surgery, have an available vein conduit, and have high limb threat and complex anatomy are likely better served initially by an open bypass, whereas many patients who present at lesser levels of severity would normally be approached from an endovascular standpoint. And there's large areas of the population for which there's no clear known advantage. The point of this is to guide the discussion with the patients so that there can be truly informed decision-making that takes place, rather than just providing a one-size-fits-all approach. The global system and the plan framework allow us to provide a personalized medicine approach to the treatment of CLTI. Thanks so much for your attention during this talk, and we'll look forward to subsequent discussion at the end of the webinar. Okay, our next presenter is Dr. Misty Humphreys, who's Associate Professor of Surgery and Chief of the Division of Vascular Surgery at UC Davis. Dr. Humphreys specializes in revascularization for peripheral artery and venous disease and has a longstanding interest in CLTI, is a funded researcher, and particularly has interest in using telemedicine to improve limb salvage care in rural communities. So with that, we'll move on to Dr. Humphreys' talk on using the VQI CLTI calculator to estimate patient risk.
Thank you for the opportunity to present today, and I'm thrilled to be here to talk about risk calculators whenever we're treating patients with chronic limb-threatening ischemia. When we think of chronic limb-threatening ischemia, we're really talking about end-stage peripheral artery disease, which is rest pain and tissue loss. When I see patients with this disease, I talk to them more about how we put their disease into remission, but we really don't cure this disease. When we see somebody with chronic limb-threatening ischemia, we know as providers that there is a mortality risk for all comers, somewhere between 10 and 30% at 1 year, and that there is a rate of amputation above the ankle, meaning below the knee or above knee amputation at 1 year, that ranges from about 8 to 25%. Even in the most optimized healthy patients with chronic limb-threatening ischemia, the 1 year mortality is about 10 years, and there's still a risk of major amputation somewhere between 8 and 12 years at 1 year. The other thing that we don't always understand as providers is that patients with chronic limb-threatening ischemia have pretty poor health-related quality of life. This is a disease that impacts every day of their life and how they go about their activities. And to just kind of go back and harp on this a little bit more, when you look at the 5-year mortality for patients who have a diabetic foot ulcer in red, a minor amputation in blue, chronic limb-threatening ischemia in pink, or a major amputation in black, you're really talking about a mortality that parallels lung cancer, which is the malignancy that has the highest mortality. Now, chronic limb-threatening ischemia presents something like this, a foot with a wound. And it's easy to think of it as one kind of disease process, but really there are so many shades of gray. And those shades of gray come in, I know what we are talking about today in terms of developing a plan for patients. Now, if you have not read the Global Vascular Guidelines for the Management of Chronic Limb-Threatening Ischemia, which is a 163-page document, allow me to help you out a little bit. The idea about plan comes in somewhere around page 59, and I'm going to go through and talk a little bit about this. And my focus is going to be on the patient risk portion of this. So when we're thinking about this evidence-based revascularization for these patients, you go through this algorithm, and this is on page 61 of the global guidelines, but you start with a patient with limb-threatening ischemia, and then you grade the limb in terms of the WIfI staging. You think about, is a primary amputation the best thing? But then when you decide that this person is a candidate for limb salvage, then you move into estimating their risk. We have a calculator I'm going to talk about a little bit later. If they are a high-risk patient, then you want to consider endo first as an option. And in standard risk patients, the determination of whether or not they should get open in endo revascularizations is really based on the GLASS classification and the anatomy of their disease. We know that physicians are notoriously very poor at predicting morbidity and mortality associated with invasive procedures. This is especially true to subjects who have multiple comorbidities or are more frail than they appear, which encompasses almost every patient that we see with chronic limb-threatening ischemia. Factors to consider for treatment of patients with CLTI are listed here: symptoms, age, comorbidities, life expectancy. But then you also have to get into healthcare priorities, patient life expectancy priorities, and then there are factors such as maintaining independence and cognitive function that also come in. And all of these can be considered in how we define high risk for surgical treatment. The evidence-based revascularization guidelines that come from the global guidelines on page 60 really talk about looking at patient risk. And when we're thinking about patient risk, you can see here 6.3, 6.4, and 6.5 recommendations. There is a strong recommendation that we estimate the life expectancy. It's really based on a low level of evidence. And when we get into talking about whether or not the patient has a high risk or low risk for mortality in terms of that procedure, the level of evidence still remains low, but actually the grade recommendation is weak. And we'll talk a little bit more about that as well. Frailty is something that we are continuously bringing up lately. And I am happy to review for everybody when we're thinking about risk calculation in terms of patients with arterial disease, the CARP trial, which is a trial that I had drilled into my head when I was younger. But we've come a long way since the CARP trial. We have better measures of who should have some type of risk assessment. And when the excitement of the CARP trial all died down, everyone sort of jumped on this frailty bandwagon. And while I might sound a little bit quip about these, both have implications of how we make decisions for CLTI patients. We use Vascular Quality Initiative to really set standards in terms of how we should treat patients, how patients are treated, and looking at outcomes. And this is a study by Dr. Crace, that was published in November of 2002. And it took the Vascular Quality Initiative data and used it to create a frailty score. They used seven different weighted variables, and they were able to predict 9-month mortality after an arterial reconstruction. The things that are the most important to see here in this visual abstract is that mortality increases significantly with age. And the more of these factors that you see on the left here, congestive heart failure, COPD, renal impairment, underweight, non-home residence, and non-ambulatory, the more of those factors that you have, the more frail you are, and then of course, the worse your outcomes are. But we have a way to predict mortality in patients with CLTI. And this is a paper that was published by Dr. Simons, and Dr. Conti was also the lead author on this. And this paper looked at VQI data, looking at the peripheral vascular intervention and the lower extremity bypass modules. About 38,000 patients in here. And it created a multivariable model using Cox proportional hazard models for outcomes at 30 days, 2 years, and 5-year survival. Now, using advanced statistics in this study, they created interaction terms for variables that are in the VQI that violated the proportional assumptions. And the authors were able to develop this prediction model that was validated and calibrated to what we have in the final calculator. The variables in the calculator that are listed here are the ones that were predictive of 30-day, 2-year, and 5-year mortality. And again, age and ambulatory status were some of the biggest predictors, and chronic kidney disease. But the other factors that you see in here, which are also able to be collected in VQI, also played a significant role in determining mortality. And these are the Kaplan-Meier curves from that particular paper. And you can see here that they broke the patients down into low, medium, and high risk. And as you look at the graph on the left, which is 2-year survival, you can see that the further out you go, there is a lower survival, and that is much more severe in the high-risk group. Then on the right side is that 5-year survival. And again, you can see that in the 5-year survival, the high-risk group, again, has the lowest survival, but you can see a difference in all 3 of those. And the authors in this paper took the opportunity also to dichotomize this outcome into a low, medium risk, which you see in blue here, and then this high risk group, which is what we translate now into the global guidelines. And so the high risk group here has significantly worse survival at 5 years. And this is what we will be using, or what I'll be kind of referring to when I talk about low and high risk patients. So how do you calculate this? That paper was then translated into the SVS CLTI mortality calculator. And so if you search for apps, the SVS IPG is on there. And then once you get into that app, there's a screen which starts with arterial, venous, and then you go down to the bottom and there is a calculator. And you can see here this VQI mortality prediction model. Once you're into that calculator, these are the variables, and this is the low, medium, and high risk groups that I just talked about. The variables that we're looking at are age, race, the indication for the procedure, kidney disease, ambulatory status, and the medications that they're on, as well as some of their other comorbidities. And then you hit that calculate button here in blue, and that helps you to get your prediction. So I'll go through an example calculation here. So here we picked a patient who was in their 70s, non-white, with rest pain, had a history of angina, but no CHF and no COPD, had chronic kidney disease of stage 2, was independently ambulatory, on a preoperative statin, smoked, previously quit, on antiplatelets, and on a perioperative beta blocker. And when we calculated that their risk, their estimated 30-day survival is greater than 99%, and their estimated 2-year survival is greater than 93%, putting them in that low-risk category. And so this is a simple tool that's very easy. I love to use this in front of patients to go over it with them and say, let's see where you are, especially for high-risk patients, to help them understand why an endo approach may be better, but also to help counsel them about where they're going to go home or a nursing facility after their procedure. What would make this easier, of course, is incorporation into the EHR. This is a study that was done at UPMC, where they took a frailty index and put that into the Epic system. And this allowed providers at the University of Pittsburgh to really screen frail patients so that it improved their 1-year surgical mortality. And this is where I see the SVS going next, is to try and partner with Epic to get some of these risk calculators in there so that we can also do it while we're doing our notes. So in conclusion, when you're talking about patients and we're doing evidence-based treatment for chronic limb-threatening ischemia, patients require a discussion of their risks. Using the SVS CLTI mortality calculator is quick and easy, helps you do that. It gives you that discussion so that patients can understand how healthy they really are. But we still need more data and more evidence in this area. And so I would encourage some of us out there that are still working on research in this region or in this area to focus on this and look at mortality. Thank you very much. And I'll be happy to answer any questions on the webinar. But if you also have other questions, you can email me personally.
Thank you, Dr. Humphries. Again, if anyone has questions for Dr. Humphries, please use the Q&A button at the bottom of the screen to submit them at any time. Next, we're going to hear from SVS President, Dr. Joseph Mills, who's Professor in Chief of the Division of Vascular and Endovascular Therapy at Baylor College of Medicine. Dr. Mills, of course, is well known to all for his special interest and expertise in limb preservation, diabetic foot, peripheral artery disease. He has been president of not only the SVS, but the Peripheral Vascular Surgery Society, the Western Vascular Society, and the Association of Program Directors. And he's co-editor of Rutherford's Vascular Surgery. Dr. Mills will explain the WIfI staging system that he helped to lead develop to estimate the risk of amputation and the benefit of revascularization. Dr. Mills.
Good evening, Joe Mills from Baylor College of Medicine, and I'm happy to be here as part of the PLAN webinar to introduce and discuss the utility of WIfI, or wound ischemia and foot infection, as part of the PLAN algorithm for the care of the CLTI patient. I have no conflicts of interest to report. I did have the following research grants, which are listed below. So just a brief introduction. Why bother to classify anything? Well, the reason is to establish a diagnosis and define disease extent, to risk stratify the patient, to predict natural history, and to predict outcomes, which would allow you to compare different modes of care. A classification system should also allow you to monitor progress and response to therapy. And the analogy I usually use for WIfI is it's meant to do what TNM did, tumor nodes and metastases for cancer. So this was published in 2014 by the group of authors listed here in conjunction with the SVS Lower Extremity Guidelines Committee. And interestingly, now in a decade, it's been cited 1,500 times. It's been adopted by numerous societies, including the SVS, the European Society for Vascular Surgery, International Working Group on the Diabetic Foot. So it's gained some traction. And briefly to introduce, why do we need WIfI? The main problem was the previous classification systems were outdated because the very concept of critical limb ischemia was never intended to be applied to patients with diabetes. And if you look back at the older Rutherford and Fontan models, they failed to differentiate levels of wound complexity and also really spectrum of ischemia. And the primary driver was infection. So if you look at this study from Urodile, if a patient had PAD, which was defined in this study as just an ABI less than 0.8, we realize that's somewhat inaccurate. But if you had PAD plus infection, it tripled your risk of amputation, and yet infection was part of neither Fontan or Rutherford. So if you think about the various types of wounds we see, from this small neuroischemic ulcer here to these large areas of gangrene here, it's a spectrum. And the wound is a spectrum, but also the degree of infection is a spectrum. And if you look at hemodynamics or perfusion of the foot, it's also a spectrum of ischemia without a single cutoff for healing. And whether you use ankle pressure, toe pressure, TCPO2, skin perfusion pressure, you get this sigmoid-shaped curve above which things are pretty normal and don't need revascularization. Most patients with severe ischemia and a wound will need revascularization, but there's a lot of patients in between that have some element of ischemia, and the decision whether it needs revascularization or not is more complicated. So the basic concept behind WIfI, which led to the Global Guidelines Committee work on CLTI, WIfI was to stratify the limb. So just like TNM stratifies the tumor, limb status stratifies the degree of wound, ischemia, and foot infection. But you also then need to consider the patient status and their anatomy in order to treat that patient. And we'll discuss that further in some of the other presentations. So I'm not going to review this in detail, but basically the grades of ischemia, wound, and infection are graded from minimal to none to most severe. The wound category actually has turned out to be the most predictive. So that's the least correctable. You start with whatever wound you're given. If you're not sure what category it is, you look at these little italics here. So you can have minor tissue loss even with toe tip gangrene. And if it's limited to the distal phalanx, that's just a 1. If the patient has enough tissue loss that they're going to require multiple digital lamps or a standard TMA, that's a 2, and more extensive gangrene involving the heel, or where a non-traditional TMA won't even be possible and you'll be forced to do a Chopard or Liz Frank, that's grade 3 wounds. So the reason for WIfI is we felt that all these things were part of a spectrum and that it was fallacious to think there was a simple, specific hemodynamic threshold for critical limb ischemia above which everything healed and below which things didn't heal. So if you look at these two grids, the one that's been explored the most is the risk of amputation, but also WIfI was intended to help predict the benefit of revascularization. And if you plot the 4 grades of wound, ischemia, and foot infection here, you get a grid of 64 possible presentations. And we ask by Delphi consensus 2 questions. What's the 1-year risk of amputation? And what's the likely benefit of revascularization for each category? So the highest risk groups were in red, H for red and high, and so forth, medium, low, and very low. And basically, even in patients with moderate ischemia, if they had sorry, I can't correct that. I don't think, yeah. If they had significant wounds or infection, they were felt to be at high risk for limb loss and also to benefit from revascularization, even though these patients wouldn't have met the previous definition for CLI, nor would these. So fortunately, you don't have to remember all this. You can click on the app from the SVS. The European also has an app, and it prompts you to enter each of the grades for those and then calculates the limb stage. So these grades are used to calculate a limb stage. And we proposed that the limb stage would correlate with 1-year amputation risk. So this was some work we did quite a while ago, but the first 8 or 10 papers that looked at WIfI, and in many of these series, revascularization was performed, but they showed a clear progression of limb loss from very low in stage 1 patients to rather high, 22 to 24% in stage 4 patients, most of these even with revascularization. So if you don't stage the patient up front, you don't know what intensity of therapy is required, and you can't predict the amputation risk. This was a meta-analysis done and published in the European Journal not too long ago, but basically they looked at almost 2,700 patients in 12 studies that met their entry criteria, and the 1-year amputation risk were respectively for stages 1 through 4, 0%, 8%, 11%, and 38% in stage 4 patients. So this is certainly a conversation you need to have with the patient up front to tell them what their risk of limb loss is, and also to accelerate care for the higher risk patients. We also think that WIfI may potentially be used to audit and compare outcomes, to improve selection of revascularization procedures, a restaging tool, and to advise patients about expectations. For example, on one of the last beds of resistance to WIfI is in England, where they use Sinbad. But this study from David Russell's group showed that WIfI stages correlated better with time to wound healing and risk of amputation, but Sinbad did not. So WIfI is an important stratifier. 2 examples here. On this group on the left are patients treated by endovascular therapy only from a Japanese group. And in red is repeat endovascular therapy rate, in green is limb salvage, and in blue is wound healing rate. And you can see as you progress from stages 1 to 4, the wound healing rate goes down, the limb salvage rate goes down, and the requirement for repeat endovascular therapy goes way up, such that in the stage 4 patients, they had an 80% limb salvage rate at 1 year, which is pretty good, but a 46% revascularization rate. And of the patients that still had their limbs, 44% had healed wounds, but that means over half, almost 60%, still had non-healing wounds. If you take this same stage 4, clinical stage 4 limb, this is a study from Conti's group at UCSF, and compare patients who underwent bypass to those who underwent endovascular therapy for these very stage WIfI 4 patients, marked difference in limb salvage for the bypass patients. What about angiosomes? Well, Jean-Baptiste Rico looked at a group of patients who underwent perineal bypass and had angiosome versus non-angiosome targeted interventions. And based on his analysis, minimal impact of angiosome, either direct or indirect, but large impact on WIfI grade. So WIfI clinical stages 3 and 4 did much worse than stages 1 and 2. This is a fascinating study from UMass, which basically looked at complexity of care, which included debridement in the OR, minor amputations, green is any revascularization, purple is open revascularization, light blue is endovascular revascularization, and brownish is plastics reconstruction. And there's a direct correlation of WIfI clinical stage to complexity of hair, suggesting that this should be possibly used as a way to drive reimbursement and length of stay in the hospital, because if you're seeing most of these patients, your costs and intensity of care are going to be higher. This study was done from UAB, and basically they used the WIfI system much like you'd use TNM for cancer. So after you treat a cancer stage and that's completed, what do? You restage the patient to assess their response. So they looked at the 1-month wound, ischemia, and foot infection grades and found that they correlated much more highly with, even more highly with limb salvage at 1 year than the baseline grades, which makes sense because if these things had not improved after 1 month of intensive therapy, they need something different or they need an alternative pathway. The other thing that WIfI allows you to do, this was from BIDMC. But if you look at this grid, you can place all the patients in each grid. And if you look carefully here, these are the patients with the highest grades of wound, ischemia, and infection. And in the bottom right here, 100% of those patients lost their limb at 1 year, 75% here, which suggests that in some patients that are in this category, if this can be validated, that conversation should begin relatively early about proceeding with a primary amputation so the patient can get on with their life and heal. The other thing that correlates with outcome, in addition to WIfI, is MAC, or medial artery calcification. It doesn't replace WIfI, but it's complementary. So both MAC and WIfI were significantly correlated with amputation risk, and they seem to be independent predictors. MAC looks at the degree of pedal calcification. So in summary, WIfI broadens the group, not restricts the group of patients who might benefit from revascularization, based on the premise that CLTI is a spectrum and not a disease with a simple cutoff. It has been shown to correlate with 1 year amputation risk, amputation-free survival, wound healing time and wound healing rate, major adverse limb events after revascularization, hospital length of stay, and hospital costs. I think that it would be imprudent not to use a staging system, just like we do for most diseases. One wouldn't treat a cancer without TNM, and I would propose you shouldn't treat CLTI without staging the limb at baseline and after different modes of therapy. I'd like to thank the SVS for the privilege of being able to deliver this and recognize the work that the Global Vascular Guidelines Committee did on this. And I always end with the point that this takes a group of people. This is our Baylor group as part of the Save the Extremity program. And we can't work on this together unless we work as groups. So thank you for your time. Be happy to answer any questions during the panel.
Well, thank you, Dr. Mills, for that excellent talk. Next, we're going to move into looking at some case reports highlighting the use of these approaches to thinking in everyday practice. First, we'll hear from Dr. David Armstrong. Dr. Armstrong is a professor of surgery at the University of Southern California, a founder and co-director of the Southwestern Academic Limb Salvage Alliance, and is a well-known international expert in limb salvage as well as diabetic foot disease. David holds a Master of Science in Wound Healing and Tissue Repair and a PhD from the University of Manchester. He's produced more than 600 peer-reviewed papers, and his scholarly output in this field is truly inspiring. We'll now hear from Dr. Armstrong with a presentation about the 3 rings of risk and his unified surgical approach using WIfI. David.
Ladies and gentlemen, it is such a pleasure to be with you today to be discussing really what hopefully is kind of a dynamic philosophy based on the Global Vascular Guidelines to try to help hopefully keep a few more legs on a few more bodies. Ladies and gentlemen, we give away all of our slides. I just ask you to copy them, make them better, and pay it forward. You could ping me whenever you like for any of these. How does that sound? And we're going to really talk now really about a unified surgical approach based on 3 rings of kind of intersecting risk, really WIfI made dynamic, because that's what it is, and that's how it works really, especially when you have kind of a toe and flow sort of limb preservation model. And so we're going to really have something of a tripartite, because things come in threes, as it were. 5 or 10 minutes together today. We're going to talk about 3 rings of risk, and in that area, we're going to broadcast our WIfI settings. We're going to talk about a surgical philosophy focused on these 3 rings, both for wound or tissue loss, for ischemia, and for foot infection. We're going to look at a case or 2 for each of those. And then finally, we're going to talk about the diabetic foot in remission. We don't have time to talk about cases associated with that to extend ulcer-free days, but more just the philosophy, as it were. But the big idea here is when we're evaluating a patient, we really have to ask, what is dominant? Is this a tissue loss dominant condition? If that's the case, well, close the wound. If it is an infection dominant condition, well, that often takes precedence. Get rid of the infection or address that. Is it an ischemia dominant condition? Well, address that. And these are all sort of intersecting rings of risk. And that's really what brings us to WIfI. And what are we talking about? Many of you have seen this already, but let's just review our WIfI settings, looking at tissue loss on the left, ischemia in the middle, and foot infection. So wound, ischemia, foot infection, making WIfI, and just like with tumor node metastasis in cancer, we really have none, mild, moderate, and severe here for each one of these things, both for the wound, for tissue loss, none, mild, moderate, severe, as you see here. For ischemia, none, mild, moderate, severe, depending on if you're looking at hemodynamic or tissue perfusion related issues, and for foot infection, none, mild, moderate, severe, based on the Infectious Disease Society of America's guidelines. So that is the big picture here. The thing about this, though, is that these are always changing and they're always intersecting, and this is dynamic. And that's why the team has to be dynamic in an interdisciplinary sense in addressing these. But now let's talk about together as a family, if you will, maybe surgery, addressing wounds, addressing ischemia, and addressing foot infection in that order. So if we're looking at addressing tissue loss, the big idea here is what causes diabetic foot ulcers or purely neuropathic ulcers in the face of neuropathy is pressure times activity. And that's what leads to this sort of imbalance that essentially allows a patient to wear a hole in his or her foot. And you have to bring that imbalance back into balance. That's the big idea behind any kind of surgery that you might be doing, trying to close up a wound, or at least in the reconstructive type, because there are really two flavors to non-vascular diabetic foot surgery, and those are reconstructive foot surgery and then just getting the wound closed. So let's just briefly look at an idea of a reconstructive type of foot surgery. This is a patient after a proximal transmetatarsal amputation, and you see his foot is in a varus position. And so you see here Tanzim Khan, one of my partners. At this time, he was my fellow, doing a tendon transfer, just bringing that anterior tibial tendon over just to give it some good balance. And in doing that, you can bring something that is out of balance and probably not very functional into balance and be very, very functional so that he can have more activity as this patient, moves through his world. Another type of surgery that one can do in terms of tissue losses, wound closure surgery. And here we really have a couple of varieties. You have split thickness skin grafting. You see this done for a fasciotomy, but theoretically it shouldn't be much different than this done for a guillotine TMA, as you see here, or for a plantar diabetic foot wound, assuming that you can spread the force over the entire unit area, as you see here for this plantar foot wound that had a simultaneous tendon balancing and panmetatarsal head resection. And what you see here from data from almost a decade ago now is that indeed that is the case. For just about 100 patients, we saw almost 7 in 10 patients have complete incorporation of a skin graft, a 20% required revision, but that was usually pretty minor. And almost all of those patients that required revision were the sickest patients. They were those patients that had CKD stage 5 most commonly in this patient population. So you shouldn't feel like skin grafting is verboten to close a diabetic foot wound, especially after you've optimized the patient for ischemia and foot infection. And here you have a patient who has a wound on his posterior heel. He was scheduled for a high-level amputation. But instead of doing a skin graft, and you see me doing a partial calcanectomy here, my partner Keaton Patel at the time did a superficial circumflex iliac pedicle or skip flap. And this kind of free tissue transfer that is not very metabolically demanding can be really attractive in this patient population. And so that is yet another way to close these wounds. Now let's move on from infection, or I should say for wound closure surgery, to ischemia surgery. You don't need me to show this, but this is a patient of Joe Mills and me. And this is the angiogram beforehand. This is the result after Dr. Mills did an angioplasty, as you see here. Beautiful, almost 70 millimeters of mercury of flow there. And now, after that, all we can do is just close that wound. And you see the skin graft here on this patient, which had a previously cadaveric leg and a BKA on the other side. And all she wanted to do was dance at her mother's, I should say at her granddaughter's quinceañera. And you see that happening right here. And there she goes. She's doing the salsa in the hallway. Almost fell, freaking out the nurse, but all is well. If these patients are going to get in trouble, we want them to get in trouble doing something, not doing nothing, right? So finally, just very briefly, let's talk about foot infection. This usually takes precedence over both ischemia surgery in terms of timing and wound closure surgery. But you see here, this is a patient that has that was referred to my partner, Greg McGee, who's on vascular. He identified maybe a little bit of pus there dorsally. This tracked all the way up the leg. So you see here, this is a simultaneous procedure being done with my Flomigo, Greg McGee, who also did an angioplasty under the same anesthesia. That then was VAC'd and later converted 4 weeks later to a skin graft, which you can see here, step by step by step, wound infection, wound ischemia, and wound closure surgery in that order. We don't have time to talk about this, but I'll just briefly say that, looking at not just at foot ulcers, but their recurrence or ischemia and its recurrence is the flavor of the day. Nothing ruins a good surgery like follow-up. And let me just show you this. After 1 year, about maybe 4 in 10 of these patients are going to get another wound. It's about 2/3 at 3 and maybe 3/4 at 5. So recurrence, ladies and gentlemen, is not only common, it's darn near likely in this population. So if the foot in diabetes is a little bit like a cancer, and we haven't talked about that in this lecture, but if we look at cost and complications, one could make that argument that maybe when people are healed, maybe they're not healed, maybe they're in remission. And this is it sounds like a coin of phrase, but it's really, really important, because if you think about it this way, if we assume that this patient is going to get a recurrence of their wound in their long life, or a recurrence of their ischemia in their long life, then the goal here is to maximize those ischemia-free days and those ulcer-free days and activity-rich days for that patient population. So, ladies and gentlemen, in conclusion, we end where we started, with these 3 intersecting rings of risk, this sort of unholy trinity of tissue loss, ischemia, and foot infection. And our goal is to bring this imbalance really into balance, in order. And it doesn't stop when the patient leaves the operating room. It doesn't stop when the patient leaves the clinic. This is over his or her entire life, from the alpha to the omega. And here's to making a difference for our patients and helping them move through the world a little better each and every day. Ladies and gentlemen, thank you so very, very much.
Thank you, David, for that excellent presentation. Next up, it's my pleasure to introduce Dr. Leanne O'Banion, who is Associate Professor of Surgery at UCSF Fresno, where she has been a faculty member since 2017. Leanne her clinical research has been focusing on limb salvage, as well as developing early recovery pathways for vascular amputees. And her presentation is entitled "No Two Legs Are Alike: Bringing Patient and Limb-Based Approaches to CLTI." Dr. O'Banion.
Good evening. I'm going to be presenting on a case presentation demonstrating that no 2 legs are alike, and we're going to be discussing patient and limb-based approach to CLTI. And I'd like to thank the SVS for the opportunity to present this. These are my disclosures. So I'm going to be discussing the patient, who's an 84-year-old male with diabetes type 2, hypertension, hyperlipidemia, coronary artery disease, and CKD stage 3. He's a former smoker, and he does have a history of a left femoral endarterectomy and common femoral artery to below knee popliteal bypass with PTFE in 2016 at an outside hospital for intermittent disabling claudication. According to the records, this occluded 7 months postoperatively with only returns of intermittent claudication, and thus he was managed medically. So we're going to be discussing the left leg first. So he presented to me in May of 2023 with an ischemic left great toe. Status posed a parrot bite by yours truly, Kiwi, here for the past month. This wound's been present. You can see it appears to be a full thickness eschar of the great toe, and then he's got some scattered eschars over the second and third toes. When discussing his ischemia, he underwent non-invasive perfusion measurements in our vascular lab. His ABIs were non-compressible, and on the left side, he had a great toe pressure of 23. He also underwent an arterial duplex, which demonstrated that the bypass was occluded, which we knew. And then he had SFA and popliteal severely dampened monophasic flow, as evidenced here in the ultrasound. His anterior tibial artery appeared to have a chronic total occlusion, and he had only posterior tibial and perineal runoff. You can see the posterior tibial artery duplex here on the screen, which shows the monophasic flow, and also you can see the echogenic calcifications demonstrating the severe heavily calcified disease of his tibial vessels. The diagnostic angiogram shown here demonstrates his anatomic complexity of disease. You can see here that he has about a 5-centimeter chronic total occlusion of his distal SFA and popliteal that is heavily calcified. His tibial vessel runoff was intact with an intact TP trunk and posterior tibial and perineal runoff, which confirms the ultrasound findings. And then distally, he has an intact posterior tibial artery onto the ankle. However, he does have a heavily diseased pedal arch, and it does not reconstitute the dorsalis pedis or distal anterior tibial. So when discussing his glass staging, you can see here that his femoropopliteal grade would be a grade 3, his infrapopliteal grade would be a grade 0, and then his inframalleolar or pedal descriptor would be a P1 due to the absent and severely diseased pedal arch. So what is this patient's plan? Well, if you look at the VQI risk calculator, he has about a 10.9% risk of in-hospital postoperative myocardial infarction, which is increased from the average, which would be only about 1.8%. And so he really falls in that 4th quartile of high-risk category. The lung severity, he would be graded as a WIfI stage 4, as he has a wound 2, ischemia 3, and no foot infection. And then his anatomic complexity of disease places him at a glass stage 2. And so when we think about the plan for this patient, there's a few other things that we want to consider outside of the patient risk, limb severity, and anatomic complexity of disease that really matter in terms of our revascularization strategies. First is going to be conduit availability. This patient had his greater saphenous vein harvested on the right side for a coronary artery bypass grafting done remotely. But he did have contralateral GSV available, which was good in caliber. The other thing to consider was that he had a redo groin and below knee popliteal exposure. And so he would require revision of and redo exposure if we were to elect for an open procedure. And then the third thing that I think is really important is also shared decision making, and really having that conversation about the plan for the patient and their considerations of conduit availability and risk of redo groin exposure, and coming up with a decision together that we could both be happy with. So after a long discussion, the patient opted for an endovascular first approach, which I was on board with and felt was appropriate in this scenario, given his short segment occlusion, redo groin, and lack of ipsilateral conduit availability. So he underwent percutaneous transluminal angioplasty and stenting of his popliteal artery, and underwent non-invasive perfusion measurements 1 month post-procedure with an increase in toe pressure to 75, and an arterial duplex, which demonstrated a widely patent stent with now biphasic flow, which restaged him at a WIfI stage 1. And as you can see here, within a month, all of those eschars are starting to lift. He was able to heal without a toe amputation, and he no longer had pain in the distal forefoot. So this overall was a good outcome for him. And 6 months post-procedure, I can say that he's still doing well. The stent's widely patent and the foot remains healed. But it doesn't end there. So 4 months later, he comes back to me and presents with this new wound on the right foot. Now, unfortunately, he didn't immediately come to me. His primary care sent him to an outside hospital when he developed this wound between the first and second toes. He presented to that hospital and underwent debridement by podiatry prior to revascularization, and then subsequently underwent an angiogram by interventional radiology with IVL and DCB of his popliteal and TP trunk, and according to the records, an attempted posterior tibial and anterior tibial artery treatment, which was not successful. So you can see here now he has a very large tissue defect where the second toe was removed, and a continued persistent necrosis at the base of the first toe. These are some pictures from the initial IR intervention, which demonstrates the heavily calcified nature of his popliteal artery, which was treated with IBL and DCB, and then the attempted posterior tibial and anterior tibial artery treatment. According to the IR, he did get a wire down all the way in the dorsalis pedis. However, the wire was unable to be advanced through the posterior tibial artery due to the heavily calcified and multifocal small segment occlusions. When he then presented to our hospital upon transfer, he underwent a restaging and redo non-invasive measurements. On exam, he actually did have a palpable popliteal artery. His ABIs were non-compressible and his toe pressure was 0, not surprising given the degree of ischemia in the forefoot. The arterial duplex did show a triphasic flow in the SFA and popliteal where that DCB had been performed. However, it showed severely diseased tibial vessels and the posterior tibial artery did appear patent. You can see here, this is his flatline toe pressure on non-invasive measurement. So I performed a diagnostic angiogram, and you can see here his popliteal artery is widely patent. The TP trunk looks okay. The anterior tibial, which had previously been patent and subsequently treated at the outside hospital, now went on to occlude and unfortunately did not reconstitute. The posterior tibial artery appeared to be the dominant runoff onto the foot. However, not pictured here was intravascular ultrasound of the proximal posterior tibial artery, which revealed a focal occlusion in the arrow that's pointing in the proximal posterior tibial. The IVUS catheter was not actually able to be advanced past this. There's a big heavily calcified rock there. And then you can see here on magged up imaging, there's actually multiple little occlusions of heavily calcified rocks all throughout and in the proximal common plantar artery, which is leading to significant hemodynamic stenoses throughout the posterior tibial artery. So when we're talking about his anatomic complexity of disease, his femoral popliteal segment had been adequately treated, and so I would grade it as 0. The infrapopliteal segment, I would actually grade as a grade 4 because the total length of target artery disease clearly was over 2/3 the length of the vessel because his target is actually going to be that distal common plantar artery. And then I would quantify his pedal descriptor as a P1 because the target artery does cross the ankle into the foot. However, the pedal arch is severely diseased. So what's the plan on this patient? His VQI risk calculator really hasn't changed in the last 6 months. So he's still at about a 10% risk of myocardial infarction, although he is medically optimized at this stage. He does have a WIfI stage 4, but now his anatomic complexity of disease is bumped up to a stage 3. So what else do we have to consider? Well, the conduit availability now, he still has that ipsilateral greater saphenous vein, which is widely available. He's not a redo groin, but we do want to consider his MAX score here, because when you're thinking about performing open or endovascular procedures, you want to think about not just the patency of the arteries, but how heavily calcified they are. And you can see here on the right, he has a MAC grade 4, and he might have been even a little bit higher if he had had that second toe to quantify the arterial calcifications in the distal toes. But he has the characteristic train track medial arterial calcification, and this puts him at an increased risk of amputation long-term because of this heavily calcified disease. I think these patients really don't do as well with tibial interventions with a high-grade MAX score, and so I personally do favor an open operation when you see this advanced level of disease. And so we opted for an open approach. You can see here that I have the common plantar artery and the medial and lateral plantar branches dissected out. He actually did require a common plantar endarterectomy, and I was able to put a little vein patch on top of it, as you can see in the second picture. And then we were able to plug in the bypass onto the patch. And you can see on the completion angiogram, he now has patent medial and lateral plantar branches, but you can see that really nice perfusion to the plantar surface of the foot. He subsequently underwent a completion TMA by podiatry. And then when he had a follow-up at 1 month and then 3 months again, his ABIs are not performed due to the distal bypass. However, we now have pedal acceleration time, which we use in our VLab. And you can see here he has class 1 PAT with a time of 92 milliseconds, which puts him at very low risk for amputation. And the bypass is widely patent. You can see the distal anastomosis on ultrasound here. This is a picture. I actually saw the patient yesterday. He has completely healed and he's now been restaged at a WIfI stage 1. And so when you're thinking about this patient, he had 2 very unique limbs both which required their own nuances and understanding of his patient risk, anatomic complexity of disease, and severity of limb threat to come out with the optimal revascularization strategies. I think for me, the keys to success are that the success of the first vascular procedure actually does matter. You have to understand the risk profile of the patient, limb severity, and anatomic complexity of disease, which is really key to having a plan. Consideration of conduit availability really is critical for decision making. And also, I can't underestimate the shared decision making that should always play a role. The patient really does matter, and they need to feel on board with their plan. And then after revascularization, restaging, and critical surveillance is going to be key to long-term success of these patients. And so I'm going to leave you with this, and I thank you for the opportunity to present. And I think we'll go on to discussion here.
Thank you, Dr. Orbanian. Our final presentation this evening is from Krista Abularaj, who's the Bernheim Professor of Surgery and the Program Director of the Fellowship in the Division of Vascular and Endovascular Therapy at Johns Hopkins Hospital. Chris is the Editor-in-Chief of VS Core, which is a national curriculum for our vascular surgery trainees, and the editor of the Annals of Vascular Surgery. He's a recognized expert in the management of the diabetic foot and has published extensively on diabetic vascular disease, as well as with a focus on disparities in costs of care. Chris's title tonight is The Best Laid Plan, How and When to Change Course. Dr. Abularaj.
Hello, my name is Chris Abularaj. I'm from the Johns Hopkins Hospital in Baltimore, Maryland. And today I'll be talking about the best laid plan, how and when to change course. I have no disclosures. As you've heard from the previous presenters, the plan is a structured decision-making algorithm in patients with chronic limb-threatening ischemia. It is both shared and patient-centered. It's based heavily on the SVS WIfI classification, including the estimated risk of amputation, as well as the benefit of revascularization. It's also based on the Global Limb Anatomic Staging System. After coming up with an initial treatment plan for a patient, it's imperative to perform clinical reassessments. This is meant to determine whether the chronic limb-threatening ischemia has resolved or not. If it has resolved, then the patient should undergo specialist monitoring for recurrent CLTI. If it is not resolved or is worsened, then they should undergo restaging using the WIfI classification, and based on that, a determination using shared decision-making of whether there should be a change in the treatment strategy or a re-intervention. Here's an example of the importance of frequent clinical reassessments. The patient is a 75-year-old African-American male who presented with a right great toe ulcer. He had a past medical history of diabetes and end-stage renal disease, as well as a coronary artery bypass. On non-invasive testing, he had ABIs that were non-compressible, with a toe pressure of 54 and moderately pulsatile transmetatarsal PVRs. His initial WIfI was 110, or a stage 1 limb with a low benefit of revascularization. In determining his initial plan, due to the fact that he was WIfI stage 1, we began with local wound care. However, on clinical reassessment, he had CLTI that worsened. His ulcer became gangrenous, and he developed gangrene of his right great toe. When we restaged his WIfI, what we found is that he was WIfI 210, or a stage 2 limb with a moderate benefit of revascularization. And based on this, we had a change in his plan. So he went to the operating room and underwent a popliteal drug-coated balloon angioplasty and recanalization of an anterior tibial artery occlusion. Here you can see his completion angiogram with a moderate residual stenosis of the popliteal lesion on the left. However, the anterior tibial artery angioplasty was widely patent with wide patency through his target artery pathway down to his foot. On clinical reassessment, however, his right great toe gangrene began to extend to his forefoot. His CLTI was worsening, and when we restaged him, he now had a toe pressure of 0. And so his new restaged WIfI was 230, or a stage 4 limb with a high benefit of revascularization. Based on this, once again, we had a change in our plan. He ended up undergoing vein mapping and had adequate single segment greater saphenous vein, and we performed a right above knee popliteal to posterior tibial artery bypass. The completion angiogram is shown here. On clinical reassessment, he ultimately underwent a guillotine right transmetatarsal amputation, followed by a staged split thickness skin graft. His CLTI was resolved, and on specialist monitoring for recurrent CLTI, he ended up passing away 9 years later after his initial intervention with his leg. Here's another example of the importance of frequent clinical reassessments when using the plan. This is a 68-year-old African-American female who presented with a traumatic right dorsal foot wound with gangrenous changes that involved her tendons. She had a past medical history of diabetes as well as tobacco abuse. On non-invasive testing, she had an ABI of 0.1 with a toe pressure of 43 with a poorly pulsatile transmetatarsal PVR. Her initial WIfI was 310, or a stage 4 limb with a moderate benefit of revascularization. Based on her initial plan, she had WIfI stage greater than or equal to 2. She was a candidate for limb salvage with a good 2-year survival. We believe that she needed a revascularization to heal her wound. I'll show you the angiogram, but she had stage 3 Glass anatomy. She was a standard risk patient. When we did her vein mapping, she actually had adequate greater saphenous vein. But upon further discussion and shared decision-making, she preferred to undergo an endovascular first strategy. Here you can see her initial diagnostic angiogram with a high-grade stenosis of the popliteal artery below the knee and subtotal occlusions throughout her anterior tibial artery. She underwent a log segment angioplasty of both lesions with improved flow through her target arterial pathway from the anterior tibial artery down into the dorsalis pedis artery with a patent pedal arch. On clinical reassessment, she had 90% take of her split thickness skin graft. Her CLTI at the time was resolved with an ABI of 1.08 and a toe pressure of 90. She then underwent monitoring for recurrent CLTI, with the restaging of her limb being a stage 1 with a low benefit of revascularization. However, 4 months later, upon clinical reassessment, what we found is that her split thickness skin graft had only an 80% take. Her CLTI had worsened. She had an ABI of 0.76 with a toe pressure of 45. And on restaging, she was back to a stage 3 limb with a moderate benefit of revascularization. Based on this and further discussion with the patient, she chose a reintervention. Here's the repeat diagnostic angiogram, a mild restenosis of the popliteal lesion. However, there's recurrent disease throughout her anterior tibial artery. She underwent a repeat reintervention with a long segment angioplasty with improved flow down her target arterial pathway, again from the anterior tibial artery to the dorsalis pedis artery with a patent pedal arch. Upon clinical reassessment, ultimately, she had 100% take of her split thickness skin graft, and on specialist monitoring for recurrent CLTI, she remained ulcer-free throughout the remainder of her life. And finally, one last case depicting the importance of frequent clinical reassessments. This is a 73-year-old gentleman who presented with rest pain, having had a failed FEM-POP with PTFE, a failed FEM tibial bypass with greater saphenous vein, and a failed FEM tibial bypass with PTFE and a distal vein patch. He was wheelchair bound due to inclusion body myositis, but had a very active life. He was referred for a second opinion regarding amputation. On non-invasive testing, he had an ABI of 0.37 with a toe pressure of 0. His initial WIfI was 0.30 with a stage 2 limb and a moderate benefit of revascularization. In terms of his initial plan, he was WIfI stage greater than 2. Was he a candidate for limb salvage? Some would argue that a primary amputation was the right procedure to be performed, given the fact that he was wheelchair bound. However, after further discussing with him and his goals in life, he had good 2-year survival. He needed to be revascularized. Ultimately, we would determine his Glass stage. Whether he was high risk or standard risk really didn't matter because at the time we didn't believe he had a good endovascular option. He had poor vein, but upon further discussion, we decided that an open inflow procedure would best serve him. Here you can see his initial angiogram. There is a high-grade stenosis of both the origin of the profunda femoris and superficial femoral arteries with complete occlusion of his popliteal artery just above the knee. We performed a left external iliac to profunda femoris artery bypass with PTFE in order to improve his inflow. On clinical reassessment, his rest pain had completely resolved. We then monitored him for recurrent CLTI. On repeat non-invasive testing, he had an ABI that improved to 0.47, although his toe pressure remained at 0. His WIfI at this point in time was 0.20. His limb was still a stage 2 limb, although the benefit of revascularization at this point was low. We continued to follow him, and ultimately he had an injury to his left great toe by banging it on his wheelchair. This ended up developing gangrene. His CLTI at this point remained poor, and when he was restaged with the ABI of 0.47 and the toe pressure of 0, now with the new gangrenous changes of his toe, he had a WIfI 2.20, which is a stage 3 limb and a high benefit of revascularization. And this, of course, led to a change in his plan. We performed an angiogram, which confirmed patency of his ilioprofunda bypass. We then performed a complex endovascular revascularization with drug-eluting stents extending from his tibio-peroneal trunk proximally through his popliteal artery, and then a long segment drug-coated balloon angioplasty of his superficial femoral artery. Here you can see his completion angiogram with inline flow all the way down the leg with 2-vessel runoff via both the posterior tibial and peroneal arteries into the foot. On clinical reassessment, he ultimately healed that toe amputation, and upon further monitoring for recurrent CLTI, he survived another 7 years with his limb. So in conclusion, the plan is a powerful management strategy for patients with CLTI. Clinical reassessments are the key to successful integration of the plan into your practice. Finally, patient education is a key component in shared decision-making, an important factor in achieving their long-term goals. Thank you.
Thanks, Dr. Abul-Raj, and thank all the panelists for these excellent presentations. I'm going to ask you to all please turn your cameras and microphones on now so we can join in for a panel discussion. During the course of the webinar, we've actually had a number of really excellent questions coming through from the attendees, many of which, some of which have been answered. And I would say there's a couple of themes that are worth exploring with the whole group of panelists. And maybe the most dominant theme of all is to talk about is the obstacles to doing this. And let me just particularly, let's focus on WIfI, which has now been out for 10 years, has a lot of data to support its relevance and validity. But there's still some obstacles in doing it in everyday practice. Folks ask questions about how to actually, achieve doing it in lesser resource settings. And I know some on the panel have experience with how to bring it into rural clinics and other places, and also just the ability to employ the EHR to do this in a more facile and consistent way. And I know several on this panel also have some leadership and thoughts around that. So let me put this out there, guys. Can you briefly talk about how you see addressing some of these obstacles to making this more routinely available? Let me ask David to start first. Yeah.
I was going to ask Joe Mills to start first through the chair, but now that you said that, okay. Well, there were, by the way, thank you for your superb leadership, Professor Conti. This really was excellent. So one of the things we saw was, and one of the questions was, well, what do I do if I see someone urgently and I can't get my non-invasives in? How do I need to stop everything and do a non-invasive? And we actually answered that to a certain degree because that is something you're going to come up with a lot. And there are a lot of people will say, well, I can't use this because, these things are always pending. We put pending down, and then we put our best guess as to what we think it is for the non-invasive. So we say, wound 3, ischemia, pending, probably moderate, pending, our non-invasives, and then foot infection. That's number one. The second thing is, and I think Joe can speak to this as well, because I know he worked on this with Epic, but we just make a dot phrase. Is that even I can't believe I'm using the word dot phrase. And when talking about these EHRs, but we just make one and we put in all of the verbiage, and then we will embolden the the W, the I, and the FI. I do this constantly, many times a day, and actually it's really nice because it lets other clinicians on other services that are not sort of they're kind of Wi-Fi naive see it, and they really start to get it after a while. It's really quite easy, and you could do that kind of. You could be agnostic to Epic or Cerner or all scripts or whatever you use.
Great, thanks. Leanne, you want to tackle some of the obstacles from your side?
Yeah, no, I mean, I think when I started in Fresno, we weren't readily using a lot of this. And so we were pretty, plan naive, if you will. But I reached out to Dr. Armstrong when I started using the Epic dot phrases, and he gladly emailed me his dot phrase. And so it was pretty easy to create and put into our Epic. Didn't take more than a few minutes. And then I think it's really just about, I think this was alluded to in the Q&A, was that it's just about routine. And so you get the residents involved, you get the medical students involved, and you teach them about it, and then they start doing it and they're interested. And next thing you know, it's just kind of like what you do. And we also have, because our non-invasive vascular lab tends to get a little bit inundated and overrun, and our hospital is always impacted. We actually have little handheld toe pressure devices that we can just go and get a quick toe pressure ourselves. And so you can get a pretty quick ischemia measurement in real time, even if you don't have your full non-invasive capability. So that's kind of one thing that I found to be pretty useful. And it's just about having one person who's excited about it and getting everybody on board. And then, like I said, I think it just kind of becomes routine.
Thanks, Dan. We're not going to promote a specific product, but maybe you might share, that tool, that portable toe pressure tool on the Q&A. Chris, any thoughts about this overall question?
Yeah, so we have a dot phrase as well, and we update our Wi-Fi classification at each clinic visit because it's basically a reassessment, right? You're trying to figure out, where they are, how their wound is doing, how your intervention did, and whether their perfusion improved with that intervention or not. I think, one thing that people get caught up on is the 64 different permutations, right? Like, yes, there are a lot of different permutations, but when you sort of break it down and you use it on a everyday basis, it's really not that hard to, just keep it going and score the patient. And it provides a framework for thinking about risk. And I think that's the most important thing that we've been able to teach our trainees as well. I mean, the Wi-Fi staging system, I printed it when Wi-Fi came out. We taped it to the wall. It's sitting there in the clinic. And it teaches everyone a framework of how to evaluate a patient with CLTI and wounds and to evaluate their risk and the need for revascularization. I think that's probably the most important thing that we found in our practice.
Dr. Mills, can you maybe comment from the SVS perspective also? How can the SVS facilitate making this more available in practice, for example, through even VQI and or promoting its incorporation into ICD coding and other things?
Yeah, so we did work with Epic. Epic queried us a few years ago wanting to include it in Epic. So it is available in Epic, and according to a person I talked to at UNC, they can just pull it up. In our Epic, we can't do that. So we have a dot phrase one of the residents created, and then I use that. I have a screenshot saved of the color grid. I just like the 4 colors. And I put that in every single note on my patients when they're consults and also in clinic. So we just incorporate it. So our lab, I've always worked in a vascular surgery clinic that had a vascular lab since I was a resident. So not having a lab in my office would be really foreign to me. We do have a lab in the hospital, but they're inundated with venous ultrasound requests for people that might or might not have DVT, and it sometimes takes them a day or two to get to the study. Also, their toe pressures aren't as accurate. So that is a problem. I think what you have to keep doing is talk to the administrators, talk to the lab, get involved in the lab, and try to improve the quality of it. As far as promulgating it, I think it is taken off. I mean, I remember taking a course from evidence-based medicine people up in Canada a few years ago, and from the time something is demonstrated to actually be beneficial clinically to where it's more broadly implemented, even from randomized RCTs, is 10 years. There's a lot of resistance to changing practice, even when the practice is not perfect, and it is. It's what you're used to, right? So I think webinars like this, I think the recent international working group on the diabetic foot guidelines that we did together with the European Society and the SBS. So rather than having 3 different societies come up with 3 different guidelines, we did it jointly. And the IWDGF includes the whole world and a lot of people who aren't vascular surgeons. I think most vascular surgeons get this because you're trained in hemodynamics. Some of the other specialists, not so much because they're trained in lesionology, but I think we need to work with our toe compadres and wound care people to measure it, right? David always says, if you want to manage it, you have to measure it. And admittedly, some of the measurements we have are imperfect, but as all these examples showed, you can apply them to lots of patients and they actually tell you a lot, right? So as far as reimbursement, that's a more complex issue. I think eventually reimbursement should be driven somewhat by WIfI stage, because there's no question that the length of stays are going to be longer in some of these patients, and the number of procedures they're going to require is going to be more. And to get penalized, for example, for having to redo something when it's what the patient needs doesn't seem fair, right? But that's a whole nother kettle of worms.
Thanks, Joe. I want to thank Dr. Humphreys for joining us at the end of a long and busy surgical day. Misty, everyone really enjoyed your talk. And one of the questions that we're talking about here is something that you know a fair bit about, which is some of the obstacles and challenges to employing the schemes in less resource intense settings, such as rural communities, trying to get standardization around staging and measurement. Could you maybe share some of your learnings in that regard as someone who's really been pioneering that?
Thank you. I think it's hard. I think that actually we get so used to having the best kind of techs and being able to do ABIs and being able to do toe pressures whenever they have calcified vessels. And what I think we don't understand sometimes is the protocols and the things that we use at our own facilities are not anywhere near what they've been using in their ultrasound techs, or they're not trained very thoroughly. I found it very hard to try to get wound care clinics to adopt WIfI. And that was one of the big endeavors I had when I started to try to build these collaborations. And because the CMS does not require us to be reimbursed by that, and they're just stick to Wagner stage, it's really frustrating to try and get that adopted. And I think that's a place where we could make a big difference.
Thanks. Yeah, for sure. I mean, coding and reimbursement might be the next major hurdle to address with WIfI. One other
Mike, I mean, what I was going to say, Mike, is nobody does anything unless you force them to sometimes. And the force comes from the way CMS is. And I know that's a very cynical way to look at it, but we've seen that over and over. We've seen it in multiple areas. So we really do have to force it with those ways because it's the right thing for the patient.
We only have a few more minutes, but one other major theme of questions was around how and when to do restaging. Is it based on timing? Is it based on clinical? Is it based on both? Maybe just a quick circle around about whether or not people just do this automatically, routinely, or selectively. Chris, that was sort of a focus of your talk. You seem to indicate it's kind of a standard practice. How exactly do you do it?
So in our group, basically every time someone comes for a visit, they get restaged automatically. I would say that the wound and foot infection are very simple. That gets restaged every time they have a clinic visit. And then in terms of restaging their vascular perfusion, we treat an endovascular intervention almost the same way you would treat a bypass. So, every 3 to 6 months for the first year, yearly thereafter, assuming they don't have any problems and don't have any restenoses. And that allows us to sort of reassess their vascular perfusion and stage the whole limb and the risk of the limb.
We'll just go around the horn here. Misty, how often and how do you do restaging?
I tend to restage them after any type of intervention. And then, of course, after treatment with antibiotics and different things like that to discuss the infectious process. But I didn't think about restaging them until I hung out with many of the people on this call for a while. And it really was that idea that we needed to restage them. And I think David was somebody that really pushed me in that regard to redo imaging for osteomyelitis, to repeat the toe pressures after I've done an intervention and different things along those lines.
David, what do you teach your podiatry brethren about how often to, especially if they're like not in a team environment and they're working with a provider in the community for vascular care?
Yeah, that's a great question. By the way, even if it wasn't a great question, Mike, I would say, Mike, that's a great question, but that is a great question. But on that, look, I think sometimes for the not, I got Joe to laugh. I think one of the things that Joe and I kind of found when we started working really closely together, too closely actually for a long time, was that, a lot of times for maybe the non kind of team approach, if maybe a podiatrist is seeing it on the outside, he or he may say, okay, well, Dr. Abularaj has done his endo or open wizardry. I check it off the list. Ischemia done, or infection done, and so then you sort of then it becomes 11th on your 10 most important things to do. And I think what you have to try to do is just to understand that these things are always moving. These rings of risk are always moving and evolving. It's like that, and so we try to check this and restage it every time we see the patient, or we say, is 121 was originally, and that just gives us a really good idea. And this checklist of just none, mild, moderate, and severe for each thing that we're constantly thinking about really just helps us ask, what's the dominant problem? And it's either tissue loss dominant, which is probably the easiest to deal with. It's ischemia dominant, or it's infection dominant, or more commonly, it's a combination of those. And we're always asking that, and we're trying to move the patient from inpatient to outpatient to maximize their, kind of ulcer-free, ischemia-free, hospital-free, and activity-rich days. I guess that would be it. And so we have to measure it every time we do that. I will shut up now, Professor Conti.
Any final comments about restaging, Joe or Leanne?
Yeah, we schedule them. So when they're scheduled for an angioplasty, and then we try to coordinate if they're outpatient where they get their debridement done soon thereafter, assuming it goes well. Then at their first follow-up in clinic with vascular is scheduled at the time their angioplasty is scheduled, and that they get at least a toe pressure and ABI, and usually a duplex of that limb. Then for me, for vein grafts, I do it the same as I always have. For endo, it depends on what you've done. So if it's at high risk of failure, like some of these really long segment angioplasties, they're predictably going to fail. Often a third of them will fail within 3 months. So I usually bring them back in 4 to 6 weeks and check again, especially toe pressure and duplex. The other key thing is when the wound stalls. So when the wound stalls, something's not right. So the most common 3 things I think are the patient's taking too much activity and are not being offloaded. So always think of that. Number 2 is, can there still be persistent infection? Maybe it wasn't drained. I've seen infections that seem drained and they go on for weeks, improving, and then the wound looks worse. And you think, well, my angioplasty must have failed. So even I've angioed some of those people and it looks fine. And then you discover on probing the foot at the bedside with your podiatry colleague, there's some undrained pus. So infection and recurrent ischemia. So the patients with long segment endo procedures, I try to bring them back, assuming their first visit result is good, then I'll bring them back in 4 to 6 weeks. But it gets to be a problem. Even when you're a team, the podiatrists value our work, and they, like David said, if we've done a revascularization, they often assume it's immortal. And we know that, nothing ruins a procedure like follow-up. So, but I try to see the endo people more often, especially if they have more than a trivial wound and they've had a long segment multi-level intervention, because that's going to fail, right? So if it fails before the wound's healed, you're going to be in trouble. So the sooner you pick that up, the better.
I would also say that to that point, my high risk bypasses I probably see more frequently. Even when they're in the maintenance phase, it's not once a year. So that guy with the plantar bypass, spliced arm vein, multiple segments, something that maybe failed early on, and I had to go back in and thrombolize, and those I try to see really frequently and surveillance more often than not, because I think just like the complex endo cases, those have high risk of failure over time.
Yeah, you check on them as frequently as how much you trust them, right? So the less, it's like children, the less you trust them, the more often you have to check.
Yeah, I would just end by saying a couple of quick points, which is that, as many brought out, CLTI is not infrequently recurrent, and just getting through the first episode doesn't prevent the patient from re-experiencing the problem. And so this is where, you know, it becomes a chronic disease management situation, and where some of the benefits of perhaps an earlier, more aggressive strategy that's more durable may wear out. It depends on the patient and the situation. I also think that one thing we didn't talk about is for me, WIfI stage is also a marker for urgency. So when I see stage 4, and particularly when I see someone deteriorate quickly from stage 2 to stage 4, that patient is almost always going right into the hospital. Because at this point, there is no time to mess around to lose more of the foot and possibly a chance of a functional recovery. So I also use it to guide my urgency. I see we're past the end of our time. I want to thank all of our outstanding panelists for a great session, outstanding talks. Thank you for all the work answering the Q&A. Thanks to the audience for participating tonight. We had a large group of people interested in CLTI. Have a great evening.